Two peaks living where we shine so bright. She goes the host, making everything feel just right. Love, laughter, and glow, that's what we're all about. Come on, join our family, let's rain and shine. Games and challenges, excitement in the air. Friends and guests joining us everywhere.
When I started X Living Talk Show, I really wanted X Living to break the barriers, be the voice for the voiceless, and also touch on those that are termed as taboo topics, because these are the topics that make most men and women suffer in silence. Some to the point of, dying of depression, taking their own lives, just because they feel they cannot talk about it. Welcome to this week's show. I'm your host, Shiko. And today we are privileged to have a guest that is going to touch on a very touchy subject that is affecting so many people in our society, and that is infertility. Welcome to the show, Dr. Kanyi.
Thank you,
Karibu sana.
Wanjiko.
Yeah.
Thank you so much for having me tonight.
Yes, karibu sana. So we're just going to jump right to it. Infertility. What is infertility?
All right. Welcome our very esteemed viewers. I'd like by first of all introducing myself. You forgot to introduce myself. Introduce me. My name is Dr. Grace Kanyi, practicing consultant, obstetrician and gynecologist in Tarakaniti County, with a private practice in Meru County. When we were touching base and you asked me which topic you'd like us to have a chat on, I knew infertility is a topic that is quite close to me, more so because of the numbers of people that are affected. So infertility, by way of introduction, is a very important but quite neglected field of medicine. You will find it affects, out of every 100 persons, 15 of them are unable to have children. So by definition, I want us to be aware of three elements. There's what we call childlessness, which could actually be out of choice. And the modern woman, we are meeting more and more women who will tell you, I don't have children, but it's actually out of choice. So that's one arm. And then there's the other arm where there is the inability to actually have children, right? And then now for this, we tend to divide them into two, so that we're able now to know how to work up this couple. There's what we call primary infertility. And this means for this particular couple, they have never attained or achieved a pregnancy, all right? And this will affect up to close to 2% of women in the Kenyan of clients in the Kenyan population. You notice I'm using the word client because it's not a female problem only. All right, it is a man and a woman who are wishing to get a child and they're not able to. Then there is secondary infertility. This is the type where the couple may have one or two children, but they have been trying for another child and it's not happening. All right. Then also in terms of definitions, we also add age. Okay. So by definition, if a couple, especially if the woman is less than 35 years old, it means they have been trying to achieve a pregnancy for 1 year. All right. And if it's a client who is above the age of 35, now usually we say you have been trying for 6 months and you have not been able to achieve a pregnancy. Okay. That said, there are also some other subset of patients will come across and we still will investigate them irrespective of the age. For example, you have a young couple, the young woman is 29 years old. She's not able to conceive, but during your history taking, you come to find either she has endometriosis or she has polycystic ovarian syndrome. Now, certainly for her, you're not going to tell her to wait for 1 year. Something else into consideration still in that definition. It is a couple that is having regular, unprotected, are we allowed to use the other word or I use the scientific word? Coitus, right? It's a family show. We can use certain language. And regular means 3 to 4 times in a week. So kama mzee ako North Hor na uko Meru, he comes home once in 3 months.
Yes.
When you come across our desk, we'll bring that to light.
Yeah.
Yes.
So as you've mentioned that, that's part of also what I would love to know, and something that also women suffer from, because you hear a woman saying that, mi sitaenda kwa daktari, hizo maswali zote za clinic hapana. Or you also go to, as we are also touching base, we were talking about it, and I was like, hizi maswali zote, do you really need to know all this? When you come to your office and you're asking all these questions, one feels that you're probing. So maybe
yes, and we had this very interesting discussion when we were behind the scenes when we were trying to arrange for this.
Yeah.
But please understand, those set of questions are what sheds light on what your problem actually is.
Yeah.
All right. After we have gotten to know how old you are, the next bit of this question will be, have you ever been pregnant before? When you come to the gynecologist, that's a very important segment, especially if you're trying to conceive. So we encourage you to be honest with us. There's no judgment, all right? If you have had miscarriages before, it sheds light on how we are going to be able to help you. Then the next bit of question is, when last did you have your period? There has been this joke that has been running on social media, that as long as you're a pregnant woman who goes to the gynae, they always want to know the last time you had your period.
Yeah.
And then from there, we will dive down into your menstrual history. For some people, they'll be like, hey, doc, we really need to know how many pads I'm using in a day?
Yeah.
But then says yes, because if you're using too many sanitary towels, every 2 hours you're having to change, it rings a bell that you are having a heavy menstrual flow. And that informs me in terms of the investigations that we'll do. On the other hand, if you're telling me I get my periods once in 42 days, I barely soak a sanitary pad, that also does shed light. You're telling me you get cramps, very painful ones during your cycle, it also sheds light on what could be the cause for the infertility. Then the next bit of the question that many people be like, hey, now doc, you have really gone too much. We will come to ask about the number of sexual partners you have had. Of course, as we dive into these questions, for those who we have interacted with, most of them will be open to it. Again, you have created a very warm climate for the patient to know there's no judgment, and why I'm asking that question, all right? That's because one of the leading factors of female causes of infertility are blocked tubes, all right? And we know that will have occurred from a certain set of infections. So we need to know that. And then, of course, we'll come and find out how often do you and your partner actually engage in the action that leads into the production of children. And is it the proper way? All right. We know there are very many practices, but we know the only one that leads into childbearing. We'll also want to know, have you ever had surgery before, especially around your pelvis? Have you ever had chronic illnesses like TB, for example? We also want to find out, have you ever been treated for cancer? We are having more and more children, girls who have been treated for cancer in childhood, and that does have a bearing. And I know we'll discuss how we can preserve fertility for those going through cancer treatment. Those subset of questions become important. We'll also ask, do you smoke? And if you do, how many cigarettes in a day? And do you drink? And the same segment of history will also be undertaken to the male partner. So what we encourage our clients when they come, it's an engaging conversation. We'll have created a very warm climate and a very open climate for us to have this discussion. Please know it's necessary.
Where you feel no judgment at all.
No judgment at all.
And I think this information is very private. It's not like it's been spread out. It's just between you and the doctor.
Confidentiality is maintained.
So we'll get into it. What are the causes of infertility? We've discussed what it is. Now, what are these causes? You've mentioned quite a few there, but
So the causes of infertility are quite varied. I may not be able to exhaust all of them during this discussion, but just to touch on the commonest one. So we'll start with the female client. But remember, there's a male client as well. So for the female client, number one, we want to find out, so usually we have this model of the reproductive health system, which during a break we'll be able to bring the model if we have one and be able to show you. So we want to find out from the ovaries, all right, are you ovulating or not? All right. That's why from the previous health talks, we have always been trying to teach clients what is a regular menstrual cycle, all right? So that you're able to tell, is my patient ovulating or not? That's where PCOS, polycystic ovarian syndrome, now comes in as a very important factor. There's some girls, because of chromosomal and genetic issues, their ovaries will fail a little bit earlier than they're supposed to. So premature ovarian failure, that means a very young girl gets to menopause at the age of 25 and some 34. It has happened. Then moving from there, we come to the fallopian tubes, all right, where fertilization takes place. Now, various things could happen to the fallopian tubes, which could lead to infertility, and this is actually the main causative factor in females. So infections, and this could range from the sexually transmitted infections to even TB, all right, and which could cause severe scarring and blockage of the tubes. We could also have some little bit of polyps developing within the tube, which could cause some blockage. We come from there, then we come into the uterus grouper. There are some girls who will be born and they do not have a uterus. All right, and so how they will have presented is that they are coming and they're like, I've never had my period and I'm 21 years old. All right, so or the uterus, instead of the beautiful shape, for some of them it could be malformed, where there's a dividing partition in between them. It's called a septum. For some, they could be having uterine fibroids at specific locations to interfere with fertility. For some, it could be polyps. For some, it could be endometriosis. All right. Then coming from there, we come down to the cervix. Some girls have a really, really stenosed cervix, so stenosed that nothing would actually pass through without medical intervention. We also know some women, they produce antibodies against their own partner's sperm. Did you know that?
No.
It's there. Then now we come down to the vagina, and this is something I've seen recently, where the female patient, the vagina never developed. All right. And then now moving from now the anatomical structures, we have now the hormonal factors coming into play. For example, high prolactin levels. The ones who are watching me and having my clients, they know we always discuss these prolactin levels coming from the brain and how it is a very important component in terms of fertility. Then we also have the thyroid as another important cause. Being obese is also another very important cause. And when we come to discuss now, when patients are trying to conceive, weight loss becomes one of the lifestyle modifications we'll be encouraging. Cigarette smoking, cigarettes have never been our friends when you're trying to conceive. Now, for the men, majority of the factors will be centered around the quality of the sperm that they are producing, all right, in terms of the numbers, all right, in terms of the shape and how fast and forward they can move. So it's mostly centered around the production of sperm in men. But let's also not forget that erectile dysfunction in men could actually lead to infertility.
Okay.
You see that?
All right. It's quite broad.
It is quite broad, and that's why we engage and we encourage couples to come in for evaluation. Yes.
Now, you mentioned a very interesting part as we also get into now how you elevate these. You know, the patient has come in, you've diagnosed, and in it is infertility. Now, this part that you mentioned, that there are even clients who produce antibodies against their own, spouse's sperms. Is that even rectifiable? That's a done deal for them.
We'll find ways around it. So now part of the workup that we would now be carrying out, remember, it's the male client and the female client. Please remember, it takes two to make a baby. So for the female client, they will most of the time they will find, after we have done a head to toe assessment, you're now able to come and explain to them, because for some of them it will be very obvious. I have examined you and I'm finding you're having tufts of hair around your around your shin, more facial hair, some hair around your chest, which is quite indicative of a polycystic ovarian syndrome. All right. So we may be doing some blood tests to get to know the hormonal status, especially prolactins, thyroid. If it's a woman of advanced age, we want to know the egg reserve, all right, through what we call an anti-Mullerian hormone levels. Then from there, we go for imaging. We do a pelvic ultrasound, and then there's another one, which most of my clients will always tell me, Doc, that is such a painful test. We always want our patients to know a HSG is a very important test that looks at the tubes. Granted, it is quite painful, but we keep on devising ways of making it tolerable, not pain-free, but tolerable. We always make sure that enough and painkillers have been administered roughly 30 minutes before the procedure. We're able to see the tubes. If you're in very good setups, they can do laparoscopy with what we call chromoperturbation. All right. And sometimes we actually have to do an MRI. Like for the patient who we come to do an evaluation, and when you're coming to examine the vagina, you find there's no opening, we need an MRI to be able to tell how are the structures in there. Then for the men, classically, we'll be doing a semen analysis. Yes, gentlemen. I know every time we mention that, they're like, Doc, I don't have a problem.
Yeah, it's my wife.
Yeah, it's my wife. Because most of the time they have an issue with how the sample is collected. But again, it is one of the ways we actually are able to analyze this sperm. Granted, for the ones who have severe changes within their semen analysis, then it means during the treatment for IVF, you're going to harvest that sperm from the testes. So that's like some of the basics of how we work up a patient. Yes.
Now you've worked up the patient, and you've really found out that they have one of two of everything that we've mentioned. Are there ways, like, or now are they doomed? They can't have a child, or are there ways that have been devised that they can use, to get a baby?
They are not doomed to have a child, all right? We have what we call assisted reproductive techniques, all right? And one of the reasons why I was even agreed for us to do this show is because, one, assisted reproductive techniques tend to be offered more in private hospitals. Number two, insurance companies, again, don't tend to pay for fertility treatment. And we are hoping as the years go by, with more advocacy, these can actually change. And then three, hopefully one day we'll have a tax-funded public IVF center. So they're not doomed. So we have assisted reproductive techniques, all right? And these will range one from even ovarian stimulation. I know you have heard of women who will say, I've used Clomid. This is my Clomid baby, all right? But classically, some of us don't use Clomid, but there are other medications we'll give you to try and improve your chances of ovulation. Where the tubes are blocked, we'll have a discussion between surgery and what the success rate will be of conceiving versus going for an IVF. All right. Where we're not able to find an underlying cause, we'll attempt intrauterine insemination. And that really means depositing the sperms in the vagina to allow for natural conception. And then for an IVF, what again that means is that using modern medicine, again, we're able to harvest the female's eggs. And then again, we harvest the male sperm. The fertilization is done externally, and we transfer the embryos from day 3, day 5, and the woman is able to carry on with this pregnancy. All right. Like I've said, insurance companies, we really hope this is a conversation that will continue going on, where they can start paying. Now, for the ones who are not able to completely afford IVF, there are other conversations around adopting a child, and we have been able to refer some of them to these agencies. Proudly we have been able to see women actually checking that up. And then for some, understand, depending on what the underlying issue is, you approach it that way. If it's a client who the egg reserve is almost zero, you have to understand, as a baby girl, you're born with your permanent number of eggs. You don't produce any more eggs once you're born as a girl. You could be at the age of 45 and you're willing to have a child. You have been trying, we do evaluation, and we find your AMH levels are quite low. So that means your egg reserve is quite low, all right? So this a client will advise on an egg donation, all right? Yes, this treatment modalities are there. And the egg donation will be from a younger woman. All right. I'm not trying to say we get our babies as early as possible, but it's to shed light that fertility tends to decline with age for women, and more studies are beginning to show even for the men. All right. Then if it's for the gentleman and we're able to do assessment and find, oh, there ain't family jewels, all right, then a donation also could be discussed.
Yeah.
Then for the women who are born without uteruses, surrogacy is a viable option.
Yeah.
All right. And we have IVF fertility centers that actually are able to find a suitable surrogate for you.
Yes.
All right.
Yeah.
That said, we do know in the US and in Brazil, they have been able to implant uteruses. So perhaps as we move forward with time, this could be something that could be offered in this country.
Now, when it comes to IVF, I believe it's what common wananchis like us will call test tube babies. We'll have arguments around that, especially around IVF and even the surrogacy part, where you hear someone say, huyo si mtoto wako. You know, especially in the African culture, even where we are right now, those are things you cannot go telling your parents that is what we are considering. You'll find that there are those, if they want to go the surrogacy way, they'll do it. Yani watajificha. They even have to go as far as kuhama nyumbani and all that. So why is it, especially that part of huyo mtoto si wako? Could you, from the medical part of it, could you explain in depth what surrogacy is and this IF?
And the IVF.
IVF, sorry.
The reason why we have to keep on having more and more of this conversation is to demystify such statements. Is also to create more awareness that infertility is actually a problem that is alive with us. Out of every 100 people, 15 couples are dealing with this, all right?
Yeah.
And out of 100, 42% of the 15 will be having secondary infertility. So this is a problem which is alive and affecting people, all right? And rather than keeping on shunning the women, ostracizing them, creating more embarrassment, we should be offering more help. Now, to come directly to your question, these babies are as a normal baby as the one naturally conceived. What I've always told my patients is this: you have really tried the natural way.
Yeah.
And you'll find they have been trying for 10 years, some even 15 years. It has not worked.
Yeah.
There's modern science where it's possible we're actually using your own egg and your partner's sperm and making a baby for you.
Yeah.
Where that is not even feasible, we're even offering an egg donation. At the end of the day, it's a human being.
Yes.
Made in the likeness of God.
Yeah.
And a child, it's how you bring them up. Even for the adopted ones, it's actually how you bring up this baby, all right? They are not less of any human beings, all right? So for some who have gone for surrogacy, they have always had these conflicts within themselves. Will I be able to love this child given that I didn't carry them? But that's because for a long time, we have always been conditioned to think you can only be a mother because you carried your child. But that's not the case, especially now where you have actually been trying and it's not working.
Yeah.
The same thing with people who are receiving organs as being transplants, as transplants. That doesn't make you less of a human being. It's actually for us to be able to embrace these women, be able to be very supportive. The one thing that I must say, the journey for infertility that when I'm working with my patients has shown me is the amount of love spouses have for their significant others. And to remember that the children that come, even for the ones that go through surrogate, I always tell them, let the child know when they come of age, I really wanted you so bad. So bad that I had to go through that journey.
Yeah.
And it's really a journey. And that requires a lot of counseling for them as they go through it. Because again, it's not always a guarantee.
Yeah.
All right, that you will spend this much money and I'll go home with a child. But eventually they do go home with a child. So the bottom line thing is, it's a human being.
Yeah. So there's surrogacy. As of course, even the purpose of the show, it's also to help you know that we assuming si kila mtu unajua pia alienda shule and it's not everyone that is getting these terms. If we could explain kabisa in layman's terms, what is surrogacy?
What surrogacy is, okay. So surrogacy in another way is gestational carrier.
Yeah.
So what that means is that another female of consenting age willingly and voluntarily carries a pregnancy for this couple.
Okay.
All right. So majority of the time, surrogacy will be advised in a couple where the female patient, for example, has severe uterine abnormalities, or that uterus not even there to start with. Okay, but she has very good ovaries. We're able to harvest the ovaries, and a very supportive partner. They're always there, and the sperm is available. But once we have now had the IVF, she cannot carry this child. So now we have a gestational carrier, a female above the age of 18, voluntarily carries this pregnancy for them. All right. The other subset could be women who have severe medical conditions, in whom carrying a pregnancy would be catastrophic.
Yeah.
All right. We have had women who underlying medical conditions. We tell them, this pregnancy will be quite something for you. All right. For others, it's because they have really been trying. Okay. They have had multiple IVFs, grade 1 embryos, perfect embryos implanted. Serially, she keeps on miscarrying. Serially, she keeps on miscarrying, and we're not able to understand why this is the case. Then a surrogate would be advised. All right. So it's a gestational carrier. That means it's another female who's carrying this pregnancy. For them. Of course, they are compensated, and how it works is that the surrogate is identified. Can meet the couple. All right. The couple foots the bills for her. All right, including her household and all that, and how the payments are done. It's in such a framework where both of them, it's a binding contract, and upon delivery, the baby is transferred to the parents. Okay. It has been quite an answer for quite a subset of women. Yes.
In Kenya, do you feel like we've really embraced the surrogacy way?
Yes, we have.
We have.
Yes, we have. Yes, we have.
In Meru?
In Meru, we have not yet met a client who fits the surrogacy. But definitely we have welcomed quite a number of IVF babies, including triplets.
Awesome.
Such a beautiful experience. And even now, some who are coming for preparation to go for season 2. Yes. So in Meru, it's been quite something to watch.
That is awesome.
Yes.
Now let's get down to the risks. Where most, even in the corridor, in social media, trying to read, maybe Google and all that, you will encounter that most people feel that with IVF, there are more risk of birth defects, among others. Is that true? And what are other risks involved with IVF?
So the art and practice of medicine is evidence-based. So that means what is the evidence that will support such a statement? Because we have seen such statements, but from highly set randomized controlled trials and also review of data, this has not quite been the case. All right, that birth defects would occur more in IVF children. Remember, you still have to control for what we call confounding factors. All right, that one, what was the age of this patient? We know risk of chromosomal abnormalities become higher as women's age advance. Number 2, why was this couple coming for IVF? It could have been that the man has an underlying chromosomal issue, so that is likely to be transferred to the offspring. So many confounding factors that would need to be taken into consideration before that can be a blanket statement.
So would you say the risks are more of the same when it comes to, the normal way of conceiving and the IVF? Do you say that they're
more or less the same? What I'm saying is you always have to control for confounding factors, which I've tried to explain. That if it was a 45-year-old who tried to have a natural conception, what is the quality of the egg for a 45-year-old lady? We know the risk for chromosomal abnormalities are a little bit on the higher side. So up until we're able to control for such, we cannot be able to say that babies born from IVF or natural conceptions, there's one arm which is having more birth defects.
You've mentioned triplets. would you say now when it comes to IVF, are you able to choose like the number of kids you want? Okay, I want twins. Is that something that I'm going to be able to like tell my doctor, I specifically want twins, I specifically want triplets? And are you at a higher risk of conceiving multiples?
So what happens, every IVF center, every fertility center will have an algorithm of the number of embryos they can transfer.
Okay.
All right. Again, depending on your age, you'll keep on finding the more the advanced age, they may tend to transfer more to increase chances of a conception. That's how you'll end up with multiple pregnancies. But is it advisable for one to go and say, I want triplets? Remember, higher order pregnancies, multiple pregnancies come with their own subset of risks. So for a client who has really been trying to conceive, depending on the age, at most a singleton, that means just one baby, or twins.
Yeah. And then there's also the argument around IVF where these babies born out of this, that there are maybe other things later in life that they're going to develop, and like, no more births.
We have not seen that as yet. We have not seen that as yet. And IVF has been around for quite a number of decades. Yeah, we have not seen any negative effects or outcomes in babies born from IVF.
Yeah.
Like we said, they're normal babies. Yeah.
And would you say it's true that infertile women are at a high risk of cancer?
Now, that's a very, very interesting...
Because this is another new argument.
Very, very interesting question, which I will very, very carefully answer. All right?
Yes.
A lady who is facing infertility, your question is, a lady who is facing infertility, is she at a higher risk of developing cancer? So let's look at the commonest female cancers. So we have breast cancer, we have endometrial cancer, which women will call uterine cancer, and we have cancer of the ovary.
Yes.
What are some of the shared risk factors among these three common cancers with infertility? You will find not having a child altogether puts you at risk of breast cancer and uterine cancer.
Wow.
You'll find not breastfeeding puts you at risk of breast cancer.
But
you didn't know that?
Okay.
The more you breastfeed, the more babies you're breastfeeding, the lesser your risk of breast cancer.
Anyway.
All right?
All right.
You'll find obesity puts a woman at risk of endometrial cancer. I'm using uterine cancer interchangeably because that's what the public knows.
Yeah.
You'll find an obese woman who is also diabetic has a higher risk of developing endometrial cancer. That's still the same patient who you're seeing for now infertility.
Okay.
You'll find patients who are on follow-up for polycystic ovarian syndrome. The reason why we are so actively managing them to make sure they at least are having a menstrual cycle once in every 35, if not 21 to 28 days, is because with PCOS, when it's untreated, you have estrogen acting on the inner lining of the uterus for a very long period of time.
Yeah.
This leads into what we call endometrial hyperplasia. Too much thickening of the inner lining of the uterus. If this keeps on going on for a long period of time, that also becomes a risk for endometrial cancer. So what am I saying? It's the shared risk factors.
Yes.
It does not mean the patient who has infertility is at the shared risk factors. For the infertile couple, you'll find either they're obese, either they have PCOS, or they have taken too long to actually get these babies, now what we call nulliparity. Then the age at which they're breastfeeding a first child is much longer. And then for some of them, because of the hormonal treatments we put them on, they're going to attain their menopause far much later. So it's the shared risk factors. So I hope that has come out very, very clearly to anyone who's watching us. Don't go saying infertility is equals
cancer.
No, it's the shared risk factors.
It's a shared risk.
All right? Yeah.
Okay, now we'll take a short commercial break. And when we'll get back, Dr. Kanyi will be explaining more on infertility. I feel this is a subject that needs to be discussed more and more often because so many people are suffering, so many couples are suffering. We'll be right back.
2 weeks living where we shine so bright. She goes the host, making everything feel just right. Grace Park Hospital echoes through the hall. Grace Park Hospital, answering the call.
Welcome back. We'd also love to thank our hosts for this show at Grace Park Medical Center. We'll put in all the details and all the services that are available. Karibu sana daktari.
We are still here.
We are still here. Nataka kuguzia kitu ambayo inaweza fanya tupigwe mawe kidogo by the other gender. But it has to be said, it has to be mentioned. So you'll find situations, and we also live in a society where if you mention infertility, it's directed to the woman. Mwanamke ndo umeleta hii, and we've heard of so many wrangles, so many women who've been chased out of their homes just because they are infertile. And you know, situations where you find the woman has gone to through the series of tests na ako sawa. But when we get to the point where we are telling the man to go for the test, apana, mimi niko sawa, wanaume tunakuanga sawa. So let's demystify this, and how do we bring them in
into the consultation?
Yes.
You bring out a very important thing we've been seeing in the consultation rooms.
Yeah.
Majority of the times when a client is coming for infertility services, it is always the female client. All right. Now it's upon us to always ask, na mwanzako ako wapi?
Yes.
All right. Also, women tend to advance that narrative. You know, men. So it's for us to continue having this conversation. It actually takes two to make a child. And even during the consults, granted the lady has come, we'll attend to her, but we still will go on to offer her this health education to know we still need to find out what's happening to the man, because he could also be a cause of why you're not able to conceive.
Yeah.
So it is important for men to really accompany their significant others to the gynecologist clinic. Please understand the gynecologist sees both men and women. That has been the misconceptions for quite a while. But for when it comes to sexual dysfunctions and reproductive medicine, we are able to take care of men to a certain extent. Granted, there's certain things we will send to a urologist, but would like the starting point where couples are not able to conceive or sexual dysfunctions. Let's start it in the gynecologist office. All right. With more kind of these talks, with more demystifying. All right. And of course, with more gynecologists being very warm and being open and receptive, we are able now to tell the men that there is also a male factor in reproduction. Remember, it's half of the female and half of the man, right? And we have had situations where we evaluate the female and everything is optimum and everything is 100% okay.
Yeah.
And then we invite the man, and that's where we find what the problem would be. The most important thing for them to know is that we also have treatment modalities for them. We are still able to harvest that sperm. Even if you have to go for it in the testes, we'll go for it. And you'll end up getting your own biological child.
Yeah.
Right?
Yeah.
Yes.
Now,
and looking at it, it's the women who actually go for more invasive tests. For the men, they can come and we'll share how we actually get this semen for the semen analysis to be done. Let's take one for the team.
Yeah.
Yes. Yeah.
Now, in your own experience, would you say our traditions are making it difficult for more people that are suffering out here to come for the medical, solutions?
Definitely, yes. And that's because of that perception that fertility is a female problem. All right. And that's one. Number two, the high costs of managing infertility really puts off quite a number subset of women. I also work in a public hospital. And after the consults and you're beginning to write the imaging, what tests do we need to do? Sadly, some of these are not available in the public hospitals. So it means it's another out-of-pocket expenditure. That is also a hindrance, all right? When it comes now to IVF itself, like we stated earlier before, very few insurance companies are actually paying for IVF. That's another hindrance. And so we want this to be more of an ongoing conversation. We start getting to the point where we are normalizing infertility, the same way we normalized HIV. And now people are very comfortable taking their ARVs. Let's get to the point where infertility is an open conversation. The treatment modalities, we keep on sharing for them. We keep on advocating for them. The cost of managing infertility really needs to come down, because those are some of the significant barriers we are facing. All right. And then because it's something that people keep on shying away from, so people keep on wanting to hide, all right, and suffer in silence. And that's why we are doing this, to raise the voice on their behalf. Okay,
Daktari, tumeshukuru sana. You've really taken your time out. I believe our audience has learned a thing or two. And maybe something we've not touched on, or something that you'd love the audience to know?
What I would want them to know is that as someone who's very interested in reproductive medicine and infertility, I have been part of a conversation with a fertility center, which we shall not name at this point in time, because it's still work in progress and behind the curtains. And what we are aiming towards is being able to have a team from this specific fertility center coming into the region. And coming into the region means they're within access. So at most 45 minutes from Merutown to where it shall be. Again, it shall not mention the hospital because it's still work in progress. So for now, what I have been tasked to do is to be able to create a database for the patients who have been diagnosed with infertility and who need IVF. So to the clinicians, the nurses who are seeing these patients, get in touch. Like you have indicated, this will be put up on your hospital's website. You can share my number there. Let's get the database for these patients. Then once we have a date for this camp with this fertility center, we are now able to invite these patients to come with all the tests that we have done for them. All right. Again, we'll be giving feedback in terms of all the tests we need required to have been done by that time. So now when the patients are sitting with the fertility specialist, they now feel like we have bridged that gap in terms of access, in terms of availability. Now you're talking to the specialist right within 30 minutes of Merutown. I think that's quite a game changer.
It is.
And that's something that I really hope will bear fruit in the next 2 to 3 months. Where you're literally talking to that IVF specialist. When they're telling you what IVF is, you're hearing it from the expert. When you want to know what is the success rate, for example, what is the cost of IVF, I need to actually shed some little bit of light on that. Because it's still one of those things that patients have to pay out of pocket. And not little money. The range is between 600,000 to 800,000. All right. And then what is the cost of IUI, for example? What is the cost of preserving my eggs? We forgot to speak about that, but let me shed light on that. For young women going through cancer treatments, because we know chemotherapy can affect the ovaries, now we have egg preservation. For those who have to go through radiotherapy, especially of the pelvis, where we know some radiotherapy may get to the ovaries, we're actually having some egg preservation being offered. All right, so that now the female client is able to go through her cancer treatment, but her fertility potential has been preserved for her. And this has really been also quite, you should see it, quite a game changer. When someone is able to come and say, I went through cancer treatment, I'm cancer free, and here is my daughter, or here is my son. All right. So being able to bring those specialists for our clients to get a one-on-one experience with them, I really tend to think will help again remove the barrier in terms of access. All right. As it is right now, we'll be telling you, we are going to this IVF center. Where is it? You know, I have never been to Nairobi. How will I get to them? I tend to believe this will be something that will change the landscape of infertility in the eastern region. Quite looking forward towards that. Yes.
one can tell that you're really, really passionate about this, Daktari, and I'm hoping to get you again and again and again because
Drop the invite.
Yeah, of course, there are so many issues around, just not even infertility. There are so many things that we can discuss around all this. Asante sana for finding the time. And
Just a parting shot.
Yeah.
To the couples who are facing infertility, please remember you are a complete woman.
Yeah.
I always tell the women as you're going through this process, you are still a complete woman.
Yeah.
All right?
Yeah.
Irrespective of how your baby arrives, you're still a mother. Whether it will end up being an adopted child, you're still a mother. All right? Whether the baby will arrive through a surrogate, you're still a mom. Whether your baby will come through an egg donation, you're still a mom. Whether it will be through a donated sperm, you're still a dad.
Yeah.
Which is for us to create this environment where we embrace the people who are facing this problem to minimize the stigma.
Yeah. Thank you so much, Doctor.
Thank you for having me.
Karibu sana. With that part in short, I don't even feel as if I should even add anything. I sure hope that you've learned a thing or two, and if you've spoken to someone who is really going through this, I hope we've been of some help. Like I mentioned, we're going to put in all the details where you can find Grace Park and where you can find the help that you need. Thank you so much for staying tuned, and let's continue subscribing, liking, sharing. Continue bringing in, your comments, your recommendations. Let us hear what you'd love to see more. And maybe if you're feeling that there's something we've not highlighted on the show that you'd really love to know, you can always reach us. We also have a Facebook page bearing the same name, X Living, where you can drop your questions and we'll get them to the right place and we'll get the right answers for you. Thank you so much and may God bless you. See you next week.
Grace Park Hospital echoes through the hall. Grace Park Hospital, answering the call.
twende. Hata ukitetemeka umesahau ni light uko nayo. Umenikia huko ndani. Sawa. Niko huko.